Okay, so today we are going to discuss the surgical management of the male LUTS. Yesterday we discussed the medical management. Let's start with a scenario. The time starts now. 58-year-old gentleman with known benign prostate referred by GP. He is on tamsulosin and finasteride tablets for past 18 months and is known to have prostate size measuring 60 cc in the past with PSA of 2. He had complete evaluation when he was started on medical management. His IPSS was 20, quality of life was 5, and his flow rate showed a water volume of 315 ml with a maximum flow rate of 8 and a post-word residue of 32 ml. He is enjoying quite good satisfactory sexual life with his partner. He is presenting to your clinic with inability to have adequate improvement in the urine flow with a combination of tamsulosin and finasteride. How will you proceed?
Can you hear me?
Yeah, I can. Yeah.
Excellent. So I would see him in my clinic, and with all of that history available, I would talk to him about what he's looking to achieve with his urinary tract symptoms, whether he's interested in pursuing a more in-depth treatment, a more invasive treatment than tablets. I'd want to establish from him whether he has any other significant medical history that's going to impact choice of surgery, such as any use of anticoagulants. I want to know, you mentioned that he has good sexual function. I'd want to know with him whether that's a priority and that him preserving sexual function is a priority, or whether he's willing to prioritize his treatment of his lower urinary tract symptoms.
Okay, so it seems like he is struggling with weak flow. That's his main problems. He tolerated the medications for past 2 years. He do wish to preserve the sexual activity, and he's not on any anticoagulants.
Excellent. So I'd have a conversation with him. I'd try and use the NHS England patient decision-making aid for management of lower urinary tract symptoms to go through the different options with him for intervention. If he's looking to preserve his sexual function, then he's more likely to be interested in one of the minimally invasive surgical techniques that are now on offer, particularly things like REZUM and UroLift. They both got excellent outcomes when it comes to preserving sexual function. I would explain to him that although they have good outcomes for lower urinary tract symptoms, they are slightly inferior when it comes to improving flow rate and IPSS than the more invasive techniques that involve removing tissue. But I would go through all those options with him with the patient decision aid.
Okay, so what are all the various options you will be going through with him?
So I would explain to him we've got, like I mentioned, different options. So we've got the more invasive, more established techniques such as TURP and HOLEP. With his size of prostate, then he has all options available to him. So I mentioned TURP and HOLEP, but I would explain that those come with a risk to his sexual function, particularly ejaculatory function. I would explain that there's also options such as green light laser and aqua ablation, which are also both fairly invasive. And then we've got the more minimally invasive options such as UroLift and REZUM. The NICE guidelines and the NHS England patient decision aids also mention iTind, but that, in my experience, that's not widely used.
Okay. Is there any size criteria for these newer modalities?
Yeah, so the newer modalities have been proven more in the smaller prostate size. So most of them are suggested for use in men with a 30 to 80 cc prostate, and not really validated for use in men with prostates larger than that.
Okay. After going through the physician aid, the patient is quite interested in the REZUM. So how will you explain this to him, and what are your plans?
So I would explain that REZUM is a day case procedure which is routinely done under a general or spinal anaesthetic. It involves injecting steam into the prostate adenoma, so that's the part of the prostate that's become overgrown. and the steam causes necrosis of the prostate tissues via sort of a thermal effect. He would require a catheter afterwards, and he would go home with that catheter in place for usually a week. I would explain that that first week or two after surgery, most men have quite significant irritative symptoms. They can have quite a lot of pain. There can be some passage of debris and blood in the catheter. But after the catheter is removed and thereon, most men recover quite quickly from the procedure. I would explain that the McVary study suggests that there is a good improvement in IPSS and Qmax following the treatment, and that most men, although we've got limited long-term data, most men have good persistence of that improvement up to about 5 years down the line. However, there is a small subset, about 10%, that would require further intervention in that time period.
Okay, what is the mechanism by which the REZUM works?
So REZUM works by causing a thermal necrosis of the prostate adenoma. So the machine has a needle which is injected into the prostate, and steam comes out through the end of the needle, very hot. So it causes a thermal necrosis of the tissue, which over time then causes it to shrink down.
Okay. And after explaining all these things, when you are showing him the information leaflets, etc., he wants to discuss the UroLift, because you placed UroLift and REZUM almost of equally of choice. So how will you explain UroLift to him?
So UroLift is another minimally invasive technique. It's licensed, or it's suggested it can be used under local anaesthetic. In my experience, most centres are still using a general or spinal anaesthetic for it. It basically involves placing permanent prostate retractors inside, which are made of nitinol clips connected by a non-absorbable suture such as proline. Those are then implanted and retract the tissue away from the urethra. You can use it to treat prostates of varying sizes by using different numbers of implants, and it has now been shown to be useful in men with a median lobe, because you can just push the median lobe off to the side and use a clip for that. The LIFT study suggested that it's non-inferior to TURP, but in my sort of clinical experience, I'd say men don't get such a long-term good outcomes from it. We certainly see that there is a similar rate of needing further intervention as with REZUM, so there's about a 10% need for re-intervention in 5 years.
Okay, so what are all the components of the UroLift implant?
So it's made up, it looks like a treasury tag, so it's made of two nitinol small metal bars, and they're connected together by a non-absorbable sort of suture material. I think it's proline or similar to proline that connects them. One of those goes in through the capsule, and that acts as an anchor, and the other one is deployed inside the urethra, and then the pressure pulls the inside one towards the outside one, retracting the prostate.
Okay, you said that UroLift is doable in a patient with a median lobe. Is there any evidence to that?
I don't know of a paper, but I know that there is general experience. In experienced hands, most people would now say it is doable. Most people would say you use your scope to press the median lobe laterally and deploy your clip off to the side.
Okay. Is there any role for UroLift in men with retention, urinary retention?
So there's a pulsar study that suggests that there's up to 80% of men who have been catheter dependent will be catheter free and remain catheter free up to 6 months after the procedure, but there's limited sort of longer term outcomes for men with retention.
Okay. In the last minute, what do you know about iTind?
So iTind is iTind was everyone was very interested in iTind about 4 or 5 years ago, and it made it onto all the patient decision aids. But in my experience, I've never seen it used, and I don't know any centres that are using it. But ultimately, it's a nitinol basket which is deployed into the prostate and works by sort of slowly creating longitudinal incisions in the prostate, causing sort of pressure necrosis in those areas to open it up. There is a study, the urology study, which compares it with a sham, and actually both arms, the sham was just a catheter, and both arms had good improvement in IPSS. So I don't think there's a huge amount of evidence for its use at the moment.
Okay, what is the material the iTind implants are made of?
It's nitinol, another nitinol.
Okay.
Okay.
So how long the implant will be kept?
I think the implant's usually left in between 3 and 5 days and then removed. It's nice because it doesn't necessitate a catheter, so they don't have to have a catheter in whilst they're having the treatment.
Okay, that's good. The time is off now, so we will stop now. How do you think you did?
You. I think it's okay. Yeah. I think I understand, I think, how most of the technologies work, which helps.
Yeah, that's good. So for this scenario, I think your performance is more than good, and I'm quite happy with the flow, and you're able to make major decisions based upon the size of the prostate, and you have not given too much of weightage to TURP and left the newer technology on the sidelines. That's okay, maybe 2 years back, but nowadays the newer technologies are much more upfront, and it's nice to decide and discuss it equally. And just into the nitty-gritties from here and there. And I'm glad that you are able to correlate the importance of the patient's wish to preserve the sexual function. That will make a big impact on what energy source you are going to use for its prostate. And size of the prostate is important, and the median lobe is important. So I've given you a lot of informations, like for example IPS score and flow rate, but I've not given you the flexible cystoscopy. So it's a good practice that you may have asked for a flexible cystoscopy, or you can say that I will do a flexible cystoscopy because of the availability of various newer modalities. And
to assess the prostate anatomy.
Yeah, and you can bring in like a one-stop LUTS clinic. You can evaluate them because that is well supported by the GRIFT also. And regarding the decision-making aid, I think you mentioned about the NICE guidelines decision-making aid, but it's more of a GRIFT guidelines, GRIFT decision-making aid. And since you said and you're traveling towards the decision-making aid, the usual flow will be like, what are all the components of the decision-making aid, how a one-stop LUTS clinic may work. Those are all the usual questions. We discussed this briefly yesterday, so I don't want to repeat it today. Overall, patients should get the all necessary things in one go and should go home with a decision of which one he is going to use. And we discussed the REZUM first. REZUM, you've said you can be done under GA and local. There is some good push to do the REZUM under local. You said GA and spinal, but there is a good push to do this REZUM even for the local anesthesia. So it can be done. Good prosthetic block can help to have the REZUM done. So when you're explaining the procedure, it's a 9 seconds injection of water vapor, and you need to use the term convective water vapor therapy. So this works by the principle of convection, and the previous one like transurethral needle ablation, transurethral microwave treatment, they used the methods of conduction. So that's the main difference there. So that's the only selling point to see whether that will help us to make this REZUM better than the failed treatments of transurethral microwave therapy or transurethral needle ablation, which failed 15 years back. So it's a convective therapy, and it uses a predetermined needle which goes to a predetermined depth, and once you activate the handle, it will give a 9 seconds of 108 or 105 degrees Celsius quite high water vapor, and it emits from the tip at 3 different angles, each 120 degrees within them, so that creates like a 3 streams covering all the 360 degrees, creating a nice water vapor ball. And we need to make sure that the placement is good enough so that the water vapor will not leak through the previous hole. So we need to place it at least 2 centimeters apart, and it's equally good for even the median lobe, but median lobe should not be huge. It should be like less than a centimeter or centimeter and a half. That's for the resume. For the UroLift, again, I'm happy with your level of evidence and level of knowledge, but few other things, like for example, the UroLift has got 3 components. The central suture, which connects the 2 metallic things, is a PET suture. It's a PET suture, and then the both arms are like urethral end and the capsular end. The capsular end is made up of nitinol and urethral end is made up of stainless steel. And the PET suture, the PET stands for polyethylene tetraphthalate. It's nice to know few things so that will give you a good mark, since you're at one stage. Like, I wish you to go one step higher than what you are now.
Yeah.
And other than that, you're quite good with the surgical retreatment rate. You just averaged it out to like 10% in 5 years. It's approximately like 13.65% in 5 years. Small difference is okay. Here and there averaging is okay, but as you are getting towards the exam, try to remove some averages and make it with some absolute numbers. That's how you can be more good. And the evidences are like lift study, which is the first study which compared the UroLift with the TURP and helped us to establish this FDA approval, etc. And then we have the BPH6 study, which is equally a good study showing the good outcomes. I don't want you to know more about that, at least just main studies. And there was a Cochrane review in 2019 on UroLift. And for the median lobe, the main study which supported is the MedLift study in 2019. It's a little bit important historically also, because when UroLift was introduced, they themselves advertised it as not suitable for median lobe. And then we started using the median lobe. There's a specific MedLift technique, and it also has shown that MedLift UroLift procedure for patients with median lobe less than a centimeter had much better outcome even compared to the lift surgery. Possibly it's because by the time the consultants are doing the mid-lift procedure, they are very experienced. And the other thing is, we always know that if there is a patient with a median lobe, and if the median lobe is tackled even by TURP, they have much better outcome, because median lobe will cause more obstruction than the lateral lobe. And you correctly brought in the pulsar study, which is for the retention, mainly for acute retention. 52 men and approximately 81% of men were catheter free end of the procedure. And a little bit about iTind, you did well. It's made up of nitinol, and once it's placed, it is to be left for 5 to 7 days. It creates 3 incisions. You can compare it with the age-old Turner-Warwick incisions, like for bladder neck. iTind is predominantly very good for bladder neck. It's not good for a very juicy obstructive lateral lobes. Multiple studies are in progress, especially there is a ongoing UK trial, premise trial, multi-center, multi-arm, comparing iTind with REZUM, UroLift and TURP. So I'm just trying to add few things so that it gives you a little bit of more meat to your answers. When I share the recorded link, in the background you can see my learning material. So you can pause the video and you can get much more context from what I'm saying now. Okay?
Brilliant, thank you.
Good. Well done.